Abhiram Prasad. I'm a professor of interventional cardiology at St. George's Hospital. It's my pleasure to introduce the next speaker, who's Professor Ponikowsk from Poland. And as I said, I'm an interventionist, and we were just talking earlier, and he too is an interventionist. It's intriguing how his career has moved into heart failure. He's had long-standing links with the UK. He was telling me that he started his career here at the Brompton with Philip Prue-Wilson in heart failure. But then spent many years in interventional cardiology, and now is multifaceted in his career in that he's an administrator heavily involved in the ESC, writing guidelines for the next heart failure guidelines for the ESC, but also has a strong interest in heart failure, and we look forward to your presentation.
Thank you very much for this nice introduction. In fact, a small correction, if Juan Carlos allows me to make it. My first paper was under Juan Carlos when I came here to London. It was 25 years ago. Juan Carlos was very young, myself either. Yes, very young, very young. Yeah, so we both did well. So once again, thank you very much for the invitation. I would like for the next 20 minutes give you some overview of new therapies for heart failure and give you some hints what is going to be in 2016. Guidelines are obviously not breaking the confidentiality rule because I am responsible, I am chairing the heart failure guidelines for 2016, and I would like to say that the inaugural session would be next year in May, so we will present it, and I'm sure that there are going to be more and more intriguing issues here. This is my disclosure. I think that once we started talking about heart failure, I would like to give you the same kind of a perception. For the last 25 years, we all made a fundamental mistake because we were going around and saying heart failure is more malignant than cancer. Heart failure is inevitably leading to death. Actually, it is based on the 20th century data, and some of them are here. And if you look at the Framingham from work from mid last century, you will see that indeed the median survival after heart failure diagnosis was around 2 to 3 years. So indeed, heart failure at that stage was more malignant than cancer, but now, having all these clinical trials, having all these interventions, having the great development in heart failure, the landscape is completely different. And I would like to appeal to you to change our approach. Now we are going to proceed with a more promising message. Heart failure now is really treatable and preventable disease. I'm now talking about chronic heart failure, and a huge development has been made, and this is just a summary which I have received from Aldo Maggioni, showing that in clinical practice, there is a huge improvement in mortality and morbidity. Less and less patients are dying, and this is of crucial importance. All of this was only possible because our understanding of background mechanisms in heart failure are now still better, wider, and more detailed. This is just a summary of a compensatory mechanism in chronic heart failure. If you see here, once there is a damage to the myocardium, which is depicted here, there are some acute and adaptive responses in the early phase, mainly related to neurohormonal activation. These mechanisms are really favorable in the early phase, allowing the body to survive this damage of the myocardium, but later they are becoming more and more deleterious, actually leading to all these unfavorable processes. And we learned that with neuroendocrine blockades, including ACE inhibitors, beta blockers, mineralocorticoid receptor antagonists, and finally with ARNI, we are now going to break this vicious circle. And only recently, and I'm sure you heard of this, not even being a heart failure specialist, we are having a great concept validated in clinical trials. We have this LCZ concept of combining in one molecule angiotensin receptor blocker, which is a standard issue. We know this for many years. With a second very important part of the whole metabolism, which is actually inhibition of neprilysin In other words, enzyme which degrades several substances, including natriuretic peptides. It obviously conceptually looks great because it is in one go a blockade of renin-angiotensin effects, system effects, and on the other hand, increasing the favorable effects of natriuretic peptides, bradykinin, etc., etc. But obviously in heart failure, we need to validate everything in clinical studies, and we have this Paradigm HF trial, which was actually published and presented only last year. And this study clearly demonstrated that ARNI was far better than enalapril, and it is actually one of the major breakthroughs over the last couple of years. I don't want to get you in details who were these patients, how they were randomized, but actually those who planned this trial, John McMurray and Milton Packer, they did this very cleverly, trying to avoid side effects, trying to avoid a lot of withdrawals. And finally, the message is that ARNI, LCZ 696, was far better than enalapril in reducing primary composite of death and heart failure hospitalization. But even more importantly, each component of this primary endpoint was reduced, particularly what is important for us, death from cardiovascular causes, optimally treated population, stable heart failure class 2 and 3, and further reduction in death by 20%. It was not only cardiovascular death, it was also death from all causes, and even more importantly, it was also reduction in sudden cardiac death by around 20%. So a really great message for us clinicians to use this drug. Obviously, the guidelines, which we will issue next year, will tell you how to use it and what would be the place for this drug in the future. However, I'm sure that it will be a major breakthrough. The next concept we have been discussed for the last couple of years, sort of independently of neuroendocrine activation, is the potential role of increased heart rate in the cardiovascular continuum. I don't want to start with atherosclerosis. I just want to focus on chronic heart failure. As you know, as you see from this slide, there were several very strong and I would say very promising data, studies, reports showing that in chronic heart failure, elevated heart rate is associated with impaired energy expenditure. There is impaired blood supply to the myocardium, mechanical desynchrony, etc., etc. And again, we needed to focus on this particular aspect of pathophysiology and demonstrate that targeting it, we can improve mortality and morbidity. Some of you may say, okay, beta blockers are doing this, but beta blockers, they have several additional effects. So we really needed to prove it a selective drug which would slow down the heart. Now we have ivabradine. This is a quick summary of a SHIFT trial in which heart rate reduction with ivabradine improved the patient's outcome. It was a combined outcome of cardiovascular mortality and hospitalization. And if you look at the characteristics, clinical characteristics of these patients, you see that again, optimally treated patients, stable heart failure, compromised ejection fraction, and really huge improvement in patients' outcome, reduction in cardiovascular death or heart failure hospitalization. And I already mentioned that we improved the patient's mortality, but now we will be facing, naturally, more and more patients coming to the hospital with acute decompensated heart failure. This is a real problem, recurrent heart failure hospitalizations. And as you see here, similarly to LCZ, this drug is able to reduce all hospitalization and, very importantly, as depicted on this slide, not necessarily only risk of first hospitalization, but also recurrent hospitalizations. In this context, I would like to challenge your traditional approach to heart failure therapy now, showing you this slide. These are the data shown last year at the European Society of Cardiology, actually published by the colleagues who did individual patients' meta-analysis of all beta blockers trial in patients with heart failure and reduced ejection fraction. Huge work and very interesting data. For the first time ever, we have been able to see that there is a difference in efficacy of beta blockers in patients with sinus rhythm. In other words, in sinus rhythm, beta blockers did very well. There was a huge reduction in mortality and morbidity versus atrial fibrillation. In other words, in those with atrial fibrillation, or history even of atrial fibrillation, looks like that Kaplan-Meier curves for all-cause death and for cardiovascular hospitalization are imposed. In other words, we have been challenged, and this is very difficult, how we need to phrase it in the guidelines, where the beta blockers are for all patients with heart failure and reduced ejection fraction, as already said in the previous 2012 guidelines. And just for your perusal, I am bringing you the algorithm, because Juan Carlos asked me to also give you some hints about algorithms in heart failure, for heart failure with reduced ejection fraction therapy, standard pharmacological therapy. If you look at this slide, at this diagram, there is no doubt that diuretics, they need to be used, carefully used, as a separate discussion, separate section, perhaps separate half a day or even 1 day Congress meeting. The neuroendocrine blockade should be started with a combination of ACE inhibitor and beta blockers, to which mineralocorticoid receptor antagonists should be added, followed by ivabradine. However, in the context of two trials I mentioned, SHIFT, meta-analysis of this beta blockers trial, and Paradigm, the first question would be, well, this LCZ should be placed in this algorithm. Should we completely forgot about ACE inhibitor, which was a core of the treatment up till now? And what about beta blockers? I can't really reveal the next. We have this, the new algorithm ready. I can't really show it to you, but this is a really challenging task for heart failure, for the group of people who are writing the guidelines. I would like to briefly touch the issue of device therapy for heart failure. This is a fascinating area. When I started, heart failure was mainly felt as an area for losers. Furosemide, maybe a little bit of that, maybe a little bit of that, nothing else. Some drugs, some furosemide, that's it. Particularly cardiac surgeons in my department, they were always laughing at it. Perhaps this is why I went for intervention, not to be always the last in the row. So device therapy is now a real challenge, and I think a very promising area. There is evidence-based therapy, guideline recommended, no doubt, CRT, ICD, VATS. And I would like to say a little about devices with less evidence, but let me first start with CRT and ICD. Last guidelines, led by John McMurray, actually suggested that the algorithm should be extremely simple. Once the pharmacological treatment is optimized, you just need to verify further decision based on the QRS duration. If QRS duration was above 20 milliseconds, you need to consider CRT. If there was less than 120 milliseconds, there was a straightforward ICD for a certain group of patients. However, in Europe, many electrophysiologists, many interventional electrophysiologists who dealt with this issue decided that this 120 is a little bit odd number, so why not to go for everyone who has got some, for CRT, cardiac resynchronization therapy, who only may have a little bit of cardiac dysynchrony, etc., etc. But some people decided to plan a trial called ECHO-CRT. This ECHO-CRT was a great trial. It was meant to be a huge success. It was meant, planned, and actually advertised during the early phase as a success-oriented trial. We need a piece of evidence. We just wait for the trial to be finished. The trial was preliminarily finished due to futility. There was no treatment effect at all. Patients with QRS duration of less than 130 milliseconds plus mechanical dysynchrony did more or less the same as having nothing. And even mortality in those with CRT was 81% higher than in those not treated with device. So we still need to be very careful. And we take for granted that this QRS duration and left bundle branch block morphology matters. And this is actually very interesting meta-analysis by John Cleland, showing that perhaps, again, the paradigm in heart failure needs to be revisited. These are the data showing, this meta-analysis shows that this is not really about QRS morphology. This is about QRS duration. And it may well be a big debate, and I think we are open for this debate, that we need to go a little bit higher, not 130, but 140. We should rather forget about morphology. We should stick to QRS duration. Very interesting concept, and I think novel, the area of further studies. And I don't want to bother you now with AF. Again, we don't have a single study showing that patients with AF and heart failure, despite of even broad QRS duration, they would benefit from this CRT therapy. I would like to focus a little on this less evidence device therapy in patients with heart failure. You may well be aware of mitral clip. I'm actually running the ReShape trial, which is supposed to be a validation of the concept that mitral clip in patients with functional mitral regurg is going to help. And I'm sorry to say, once we started the trial, we went to the best European centers. They promised us hundreds of patients, but they should not even participate in the trial because they didn't have equipoise. They took for granted that mitral clip works. So they did not recruit a single patient. And now we went a little bit different direction. So the trial is ongoing. TAVI is another issue. I would like to mention neuromodulation. This is one of the most, in my opinion, fascinating area. Last year we published with John Flores a paper showing that there are several mechanisms involved in autonomic imbalance in heart failure, which is mainly leading to sympathetic overactivation. In brief, you have overactive afferents or inactive afferents. You can have a very complex picture. I think that we focused a lot on those afferents who are down, like cardiopulmonary baroreceptors, like vagal stimulation, which all failed. Now we are focusing on atrial chemoreceptors and on the carotid bodies. You know, this is simple. We started with surgery because it's very easy to remove carotid bodies by an experienced vascular surgeon. It was actually done many years ago in patients with asthma. So we have a very nice, and we'll be publishing this soon, very nice data that it reduces the sympathetic nerve activity. So a lot of ongoing activities, a lot of data, which soon be actually not available only as reports, but as randomized clinical trials. So this area, as I said, neuromodulation is something which is very, very interesting. And last but not least, I would like to mention comorbidities. You are aware of that we are seeing patients with heart failure with numerous comorbidities. These patients are typically older and older, and they are having numerous comorbidities, cardiovascular and non-cardiovascular. Most of them importantly affect the management, not necessarily disease progression, clinical picture, and outcome. And I would like to surprise you and just to draw your attention on something you would never believe it, because myself as cardiologist, I was very skeptical. We started iron deficiency issue many years ago, by chance, because we were interested in anemia, again, by chance. I remember that once we published the paper from my country, from my institution, the paper was immediately rejected from one of the best journals, and a couple of months later, the same kind of concept. I'm not saying that life is fair. Of course, it's not fair, but the same concept, the same paper, 5 or 8 times more patients immediately reanalyzed, published as a fast track. It's okay, because it only reassured me that we are doing okay. And investigating anemia, we found that iron deficiency is actually very common, very common. It's actually intuitively linked with anemia, which is a wrong concept. As you see here, 50% of patients in the whole population, and it appears to be equally prevalent in patients with heart failure and reduced, and preserved ejection fraction in patients with heart failure, acute heart failure. Around 50% of these people are iron deficient, and there is only tiny difference between those anemic and non-anemic. And if you see here, actually across the severity of the disease, the prevalence is actually more or less the same. So, and last but not least, iron deficiency is a very strong prognosticator. We did a study, together with Stefan Anker, we did a study where we repleted iron deficiency with IV iron. As you see here, only after 4 weeks, we had a fundamental improvement. Some very outstanding UK cardiologists, heart failure cardiologists, said, no chance, this must be wrong. You need to have a confirm. So we did the second study. We just published the second study with the same kind of design and with the same data. Again, I don't have time, and I just want to show you that iron being actually, I'm a little bit biased because we are now investigating this and we will soon start 2 large mortality morbidity trials. I'm sure that iron is a crucial element of the whole pathophysiology. Some people are actually saying that we are killing people with IV iron because they truly believe that there is an iron overload in some forms of heart failure. I don't want to get into details. However, this is the, again, individual patients meta-analysis. If you look at this blue rows, you will see that we found that in patients with heart failure and iron deficiency, IV iron reduces heart failure hospitalization, mainly heart failure hospitalization, and the combined endpoint of heart failure hospitalization and cardiovascular death. Interesting story. I take your criticism that this is not well powered, this is meta-analysis, and this is why we are starting the prospective study again and again. And the final part, virtually in 1 minute, getting back to what I already said, last decades, less deaths, but more and more rehospitalizations. As you look here, a curve describing mortality and morbidity of acute heart failure patients, 40% readmitted or death in the best European centers. We wrote a couple of years ago a summary saying that actually our armamentarium is largely unchanged over the last 40, 50 years. Perhaps we need a shift in acute heart failure paradigm. And this is what we are now currently propose. First, maybe I should start with from the last, appropriate timing. We need to borrow from acute coronary syndrome colleagues the earlier the better concept. In my institution for many years, if there is a patient acutely decompensated, not in pulmonary edema or cardiogenic shock, nobody rushes. Everybody takes for granted that a little bit of furosemide or maybe some kind of a watchful thinking would be okay. In contrast to a patient with chest pain, everybody rushes. Everybody rushes, and I am very happy. So everybody rushes, the cath lab is open, etc. It's open for 24 hours, but particularly in this case is open. So we wish to provide now the concept, the earlier the better. Prevention of tissue damage, very severe symptoms early, and hopefully stabilization and prevention of end organ damage, which is one of the most important issues. We really believe that the concept from acute coronary syndrome, that early intervention can have a long-term consequences. You may say it's not possible biologically, it is, because thrombolysis, which lasts seconds, or intervention in acute coronary syndrome, which lasts minutes, is going to have a long-term favorable consequences. We believe that it may well be applicable for acute heart failure as well, but we believe that we need targeted approach and perhaps better drugs. You tell me we don't have any evidence yet. I agree, we don't. However, we have a promising data from RELAX-1. When we approached more or less the same kind of a concept in RELAX-1, and if you see here, there is a clear signal. It's nothing more than signal that serelaxin, if all this kind of ideal population, targeted approach, the earlier the better concept is instituted, may well work. These are the data showing that mortality was reduced by 35%. We are now verifying this in the second trial, in the big mortality trial, powered for mortality. It was not powered for mortality. And the recent Eugene Braunwald concept that future war against heart failure may be only with this several novel approaches like enhancement of myofilament sensitivity, gene therapy, cell therapy. Perhaps of this, I believe in the fifth. Quite recently, we did together with colleagues the study CUPID trial, where we administered intracoronary SERCA gene to patients with heart failure, and we are very, very disappointed, very disappointed. We published this, and it will be soon in The Lancet. Barry Greenberg showed this last ESC meeting. No change at all, nothing. In some cases, even worse. So I think it's more or less like with this cell therapy. Some people say it works fantastically. So maybe this is my final slide showing which directions we need to go. Flying here, I put this slide to show that I started with Philip Poole Wilson, who always went back to physiology, who always went back to basic mechanisms, showing this very basic, very evolutionary-based kind of a biological-oriented approach to heart failure. Maintain blood pressure, prevent bleeding, combat and exclude infection. And I think there is a lot of it, and this is my conclusion. The great things is where we will be moving. Thank you.
Thank you very much.